Welcome back to the deep dive. Today, we are opening a file that, quite frankly, casts a very long shadow. It is statistically probable that the topic we're discussing today will touch your life or, the life of a parent, a partner, or a close friend.
It's almost unavoidable.
It really is. We are talking about colorectal cancer. But before you tense up, I want to be really clear about our mission today. We are not just going to be looking at the scary statistics. We are unpacking what is really a medical revolution.
That is exactly the right frame. It's a heavy topic, undeniably. But when you look at the source material we're working with today, specifically this comprehensive clinical chapter,
Right.
Chapter 61, colorectal cancer, you realize we aren't talking about a static disease anymore. Not at all.
Right.
The understanding of this malignancy has it's shifted so dramatically from,
Yeah.
cut it out and hope for the best, to a deeply complex molecular chess match.
That was the first thing that really struck me in the reading. You tend to think of cancer as an event, that moment where you say, I have cancer. But the literature describes it so much more as a process, a sequence of failures.
Precisely. It's a biological cascade, a series of unfortunate events on a cellular level. We're analyzing a malignancy that involves the colon, the rectum, and the anal canal. But to really understand it, you can't just look at the tumor.
You have to look at the timeline.
You have to look at the timeline. We're going to trace this from the microscopic genetic trigger, the very first domino to fall, all the way to the macroscopic high-tech surgical interventions that we're using today.
So our roadmap for this deep dive is to decode that entire journey. We're going to break down how we find it, which is honestly a detective story in itself, and then how we stage it, which turns out to be incredibly nuanced. And then we need to spend a significant amount of time unpacking the arsenal. And arsenal feels like the right word because the sheer variety of drugs, biologics, and surgical techniques, it's kind of overwhelming.
It's massive. And if we do our job right today, by the end of this hour, you should understand that critical transition from let's call it a local problem, something contained and often curable, to a systemic disease.
And what comes with that?
And perhaps most importantly, why terms like molecular markers and genetic profiling, well, they're basically the new gatekeepers of who survives and who doesn't.
Before we get into the heavy chemistry, though, I want to anchor us with a statistic from the source that just really set the stakes for me. The text mentions that adenocarcinomas, they account for more than 90% of tumors in the large intestine.
That's right.
So almost everything we're talking about today falls into this one big category.
It is the dominant form, yes. But here's the number that should really make you pause, and it's one that clinicians struggle with every single day. Roughly 20% of patients, they present with metastatic disease right at the start.
Let's just let that sit for a second. 1 in 5 patients, they walk in for their initial diagnosis, and well, the horse has already left the barn.
The horse is out of the barn and running down the road. Correct. That means by the time they feel a symptom, or by the time a test finally catches it, the cancer has already moved beyond the colon or rectum to distant sites.
And where does it usually go?
Most commonly, we are talking about the liver, then the lungs or the bones. And that context is so crucial because it highlights why screening and early detection are the absolute bedrock of survival.
Because once it spreads,
the game changes completely. The complexity of treatment goes up exponentially and, well, the prognosis shifts dramatically.
So let's rewind the tape. Let's go back to the very beginning. How does this actually start? The source material calls it a multi-step process. I think people have this idea that a healthy cell just, suddenly decides to go rogue overnight. But that's not really the case, is it?
No, it's almost never a sudden flip. It's more like a slow-motion car crash on a cellular level. You start with normal bowel epithelium, the lining of the intestine. These cells are constantly renewing themselves. It's a very active area. But then you get a genetic alteration, a typo in the code, and then maybe a few years later, another one. The structure and the function of these cells, they just start to break down.
So it's a cumulative failure, not one big mistake.
Exactly. Think of it like a high-security building, where the safety systems are failing one by one. The text highlights features like genomic instability. The whole system becomes fragile. And then you have the activation of what are called oncogene pathways.
I always picture oncogenes like a gas pedal in a car that's gotten stuck down. The car just wants to go faster and faster and faster.
That is a perfect analogy. The oncogenes are the gas pedal.
Yeah.
They are driving cell division and growth, telling the cell, go, go, go. But in a healthy cell, you have brakes.
Of course.
And those are the tumor suppressor genes. Their whole job is to say, whoa, hold on, stop dividing, something is wrong here. In this multi-step process, you have the gas pedal step down and the brakes are cut.
So you have the mutational inactivation of the suppressors, gas down, brakes cut. Wow.
And on top of that, just to make it even worse, you have the activation of growth factor pathways. So it's like someone is also pumping high-octane fuel into the engine. It creates this perfect storm for dysregulated cell proliferation.
The cell basically forgets how to die.
It forgets how to die, and it only knows how to grow. And this whole spiral, this cascade, it takes time. It can take years. And that is actually our window of opportunity.
Which leads us naturally to the question of prevention. If we know this is a genetic spiral that happens over, 5, 10, 15 years, can we stop it before it starts? The source mentions primary prevention.
This is the holy grail, right?
Yeah.
Stopping the fire before the match is even struck.
Primary prevention is indeed the dream. The whole idea is to intervene in an at-risk population before the cancer even manifests. And the source discusses some fascinating trials involving a drug called celecoxib.
Okay.
Now, this wasn't just tested on the general population. They looked at a very specific, very high-risk group. Right, I saw that. This was for people with familial adenomatous polyposis, or FAP. Can you explain what that is for the listener? Because it sounds intense.
It is about as intense as it gets.
Yeah.
FAP is a genetic condition where the colon becomes, and this is not an exaggeration, carpeted with polyps. We are not talking about one or two.
Not at all.
These individuals can develop hundreds or even thousands of polyps. Without a major intervention, the risk of developing colorectal cancer is, well, it's basically 100%.
So that is the ultimate test case for a preventative drug. I mean, if you can stop cancer there, you can stop it anywhere.
That was the logic. And the trial showed that using celecoxib, which is a COX-2 inhibitor, a type of anti-inflammatory, it actually did reduce the size and the number of these polyps after about 6 to 9 months of treatment.
That sounds like a massive win. You're chemically suppressing the precursors to cancer.
It is a short-term win, and this is where science gets messy and, frankly, a little disappointing. The text is very clear on this. Despite that initial reduction, there is a lack of demonstrated long-term benefit.
So the effect wears off?
It seems so. The polyps might shrink for a while, but the underlying drive, that genetic gas pedal we talked about, is just so strong in these patients that the drug can't hold it back forever. Plus, COX-2 inhibitors come with their own set of risks, particularly cardiovascular risks.
Right.
So we haven't fully cracked the code on safe, long-term chemical prevention for everyone. Not yet.
Which brings us to secondary prevention. If we can't always stop the biology from going wrong chemically, we can at least catch it when it's just a whisper and not a shout. This is where we get into the physical interventions.
Precisely. Secondary prevention is all about catching a malignancy in a population that has already started the disease process but isn't symptomatic yet. This ranges from the routine, like a colonoscopy where you remove a precancerous polyp, all the way to the extreme.
How extreme.
For those FAP patients we just mentioned, secondary prevention often means a total colectomy.
Removing the entire colon.
Yes. If the genetic risk is absolute, if cancer is an inevitability, you remove the target organ. You take the colon out of the equation. It's a life-altering surgery, no question, but it beats the alternative.
That is a drastic measure. For the rest of us, the average risk individuals, the guidelines are a bit less extreme, thankfully. Let's break down the checklist provided in the text. For the general population in the U.S., when does the clock start ticking?
The standard guidance has been age 50. Now, I should note, and this is important, that some newer guidelines are pushing that down to 45 because we are seeing an alarming rise in cancer in younger people. But the text we're focused on uses the age 50 benchmark for average risk.
And what are the options? I think a lot of people just assume it's colonoscopy or nothing, but there's actually a menu of choices.
You have a few paths. One is annual occult fecal blood testing,
which is basically checking for microscopic amounts of blood in the stool, a tiny amount you can't see.
Exactly. Tumors, even small ones, are vascular. They have a blood supply, and they're fragile. They bleed. But they don't bleed much, and they don't bleed all the time, which is why you have to do the test annually. It's a numbers game. You're trying to catch it on a day it happens to be bleeding.
But the gold standard, the one everyone talks about, remains the physical examination of the colon itself.
The colonoscopy. The recommendation is every 10 years, assuming the first one is clear and you don't have polyps. And the reason it's the gold standard is really unique in medicine. It is both diagnostic and therapeutic at the same time.
What do you mean by that?
Well, if I'm doing the exam and I see a polyp, I don't just take a picture of it and schedule you for surgery later. I have a tool, a snare, and I remove it right then and there.
So you've just stopped it in its tracks?
Instantly. I have just prevented that specific polyp from ever having the chance to become cancer. It's an incredible tool.
I think a lot of people put this off because, well, let's be honest, the prep is unpleasant and the procedure is invasive, but the source material emphasizes something really scary about the symptoms of CRC. It calls them varied, subtle, and nonspecific.
That is the silent enemy aspect we touched on in the beginning. Early stage CRC is often completely asymptomatic. You feel fine. You look fine. You're running marathons. You're going to work. You have no idea. But the process is happening inside.
And that's why screening is so critical.
It's why screening is non-negotiable. If you wait for symptoms to appear, you have often waited too long.
If symptoms do appear, what are we looking for? The text mentions blood in the stool is the most common sign.
That is the big red flag. Hematochezia, which is bright red blood, or melena, which is a dark, tarry stool that indicates bleeding higher up in the colon. But you also have to watch for changes in bowel habits. And I don't mean you had a bad meal and your stomach is upset for a day.
Right, this is a pattern.
It's a persistent change. Maybe you're suddenly constipated all the time when you never were before, or you have diarrhea that just won't go away for weeks. It's a shift from your personal normal.
And then there are the really vague ones. Abdominal discomfort. I mean, who hasn't had that?
Right. Bloating, distension, gas pains. It's so easy to dismiss that as, oh, I ate something bad, or I'm just getting older. In more severe cases, you might get nausea and vomiting if the tumor is actually big enough to block the passage of food.
A physical obstruction.
A physical obstruction. And if the bleeding has been happening slowly over a long period of time, just a few drops a day, for months, you might just present with severe fatigue because you've become anemic. We see patients who come in just feeling tired and run down, and it turns out their hemoglobin is rock bottom because of a tumor they didn't even know they had.
So let's say the screening was missed or symptoms have appeared. We are now moving into the diagnostic phase. We need to know what we're dealing with. The toolkit starts with the physical exam and history, of course. But you're going back to the colonoscopy to actually visualize the tumor.
Correct. You need to see it and biopsy it.
And then you have the labs. I want to highlight one specific lab test mentioned in the source. CEA, or carcinoembryonic antigen.
Yes, CEA. This is a protein, a tumor marker, that is often elevated in patients with colorectal cancer.
I feel like there's a common misconception that this is a screening blood test. You know, just check my CEA levels, doc, and tell me if I have cancer.
I am so glad you brought that up because it is a crucial distinction. The text states this clearly. CEA is too insensitive and too nonspecific to be used as a screening test for early-stage CRC.
What does that mean, insensitive and nonspecific?
It means two things. Insensitive means many early cancers don't elevate CEA at all. So you could have cancer, but the test is negative. That's a false sense of security. And nonspecific means that many other non-cancerous things like smoking or inflammatory bowel disease or liver problems can raise it.
So you get false positives.
You get a lot of false positives. It's just not a good finding tool.
So what's it for? Why do we use it at all?
It's a baseline and a tracker. You measure it at the time of diagnosis. If it's elevated, say it's at 50, and then you have surgery to remove the tumor, you want to see that number drop down to normal, close to 0.
Okay, that tells you the surgery was successful.
It suggests you got it all. Then, if 6 months later it starts creeping up again, it goes to 5, then to 10, the cancer might be back, often long before you can see it on a scan. It's a monitoring tool, not a finding tool.
Got it. Okay, so we found a tumor. We have our images, CT, PET, MRI. Now comes the part that seems like learning a whole new language. The TNM staging system.
The alphabet soup of oncology. It seems complicated, but it's actually very logical. It's just a system that helps us categorize the enemy so we can pick the right weapon.
Let's break it down. TNM.
T stands for tumor. Specifically, how deep is the primary tumor invading into the wall of the colon? N stands for nodes. Has the cancer spread to the nearby lymph nodes? And M stands for metastasis. Has it gone to distant organs?
Okay, so let's walk through the stages because this directly dictates survival. Stage I.
Stage 1 is a local invasion. The tumor is in the submucosa, or the muscularis propria. That's the muscle layer of the bowel wall. But it hasn't gone all the way through the wall, and the lymph nodes are negative. This is the best case scenario for a cancer diagnosis.
Great news if you catch it there. Stage 2.
Now the tumor is more locally advanced. It's invading through that muscularis layer. It might be getting into the tissue surrounding the colon or even touching other nearby organs.
Yeah.
But, and this is the key difference, the lymph nodes are still negative. The cancer is aggressive locally, but it hasn't hopped onto the lymphatic highway yet.
Stage 3. This sounds like the big jump.
This is the tipping point. Stage 3 means we have found cancer cells in the regional lymph nodes. The size of the tumor matters less here. The fact that it has escaped into the lymphatic system is the defining feature. Once it's in the nodes, the risk that it has traveled elsewhere in the body skyrockets.
And stage 4, as we touched on earlier.
Distant metastasis, M1. The cancer has set up shop in the liver, lungs, bones, or somewhere else far from the colon.
The text gives us some incredibly stark numbers regarding prognosis based on the staging.
It does. And this is why we scream from the rooftops about screening. If you catch it as a localized tumor stage I or I, the 5-year relative survival is approximately 91%.
91%. That's an A-grade survival rate. You are overwhelmingly likely to be okay.
You are. It's a highly curable disease at that stage.
But if it's metastatic, if you're diagnosed at stage 4,
that survival rate plummets. It drops to about 12%.
that is a cliff, from 91% down to 12%.
It is. It highlights that this is a curable disease if caught early and a very, very difficult disease if caught late. And even beyond just the stage, the expert source lists what are called poor prognostic factors. So even within the stages, some things make the outlook worse.
Like what?
Bowel obstruction or perforation at the time of diagnosis. That's bad. It suggests a very aggressive, invasive tumor. A high preoperative CEA level is also a bad sign. It suggests a high tumor burden.
And location matters, too.
And location matters. Anatomically, tumors located in the rectum or the rectosigmoid area tend to be more difficult to manage surgically and have a slightly worse prognosis than those higher up in the colon, just because of the tight space they're in.
We also have to talk about the genetics here. This isn't just about anatomy and location anymore. The text lists several molecular markers that can predict how the disease behaves.
This is the modern era of oncology right here. We are not just looking at the tumor under a microscope anymore. We are sequencing its DNA. We're looking for things like MSI, that's microsatellite instability. We're looking for mutations in specific genes like 18q-DCC, BRAF V600E, and the really big one, KRAS.
And we are going to talk a lot more about KRAS later when we get to the drugs, right?
Absolutely. KRAS is the gatekeeper for an entire class of therapies. If you don't know the KRAS status of a metastatic tumor, you are flying blind. But in general, these markers tell us how aggressive the cancer is likely to be and, crucially, which drugs will or will not work. It's essentially a personality test for the tumor.
Okay, so let's move to the operating table. We have a diagnosis, we have a stage. If the disease is localized, stage 1, 2, or 3, what is the goal?
The goal is cure, plain and simple. We are trying to eradicate the tumor we can see, and just as importantly, the micrometastatic disease we can't see yet.
The single cells that might have escaped.
Those lone wolf cells that might be floating around.
And the primary weapon for that is surgery.
Yes, a complete surgical resection of the primary tumor. But you don't just take the tumor, you have to take the regional lymph nodes, a procedure called a lymphadenectomy. You need to know if it is spread, and you need to remove the pathway it travels on.
How many nodes are you looking for?
The standard is you want to get at least 12 nodes in the specimen to be sure you have an adequate sample for staging.
Now, the text makes a very specific note about rectal cancer surgery versus colon cancer surgery. It mentions something called total excision of the mesorectum. What is that, and why is it so important?
This is a crucial distinction and a major advance in surgery. The colon is sort of loose in the belly. The rectum is different. It's fixed deep in the pelvis, and it's surrounded by a fatty tissue envelope called the mesorectum.
Okay.
This fatty envelope contains all the lymph nodes and blood vessels that feed the rectum. Historically, surgeons would just kind of core out the rectal tube itself and leave a lot of that fatty envelope behind.
And that was a problem?
It was a huge problem because tiny cancer cells were hiding in the lymph nodes within that fat, and the local recurrence rate was incredibly high. The cancer would just grow right back where it started.
So what changed?
The procedure now is to surgically excise that entire package, the rectum and its entire fatty mesorectum, all in one clean piece. It's technically more difficult surgery, but it has dramatically reduced local recurrence rates. The outcomes are vastly superior.
But surgery in this area, it's not without risks. The list of potential complications is, well, it's pretty unpleasant to read.
It is major surgery in a very delicate area. The immediate risks are things like infection and anastomotic leakage. That's where the two reconnected ends of the bowel leak. That's a life-threatening emergency.
And long-term?
Long-term, you're looking at potential obstruction from scar tissue, adhesions, malabsorption syndromes where you can't digest food properly. And specifically for rectal surgery, because you're working in that tight space of the pelvis, you risk damaging the nerves that control sexual function and bladder function. These are major quality of life issues.
So once the surgery is done and the patient is recovering, we enter the world of adjuvant therapy. I like your analogy for this, the cleanup crew.
That is a fair description. Adjuvant therapy is what we give after the surgery to, hopefully, wipe out any of those residual cells that might be floating around that the surgeon couldn't see or remove. We are operating on the assumption that there might be microscopic disease left behind.
But not everyone gets it, right? It depends on the stage.
No, you have to balance the risk of recurrence against the toxicity of the treatment. For stage 1, surgery alone cures more than 90% of patients. Adding chemotherapy might add maybe 1% to that survival, but it adds massive toxicity. So the risk-benefit just isn't there. No extra therapy is needed.
What about stage 2? The text says the results are conflicting.
Stage 2 is the big gray zone. There's a lack of clear consensus. Generally, if a patient has what we call high-risk features, like that obstruction or perforation we mentioned earlier, or the surgeon couldn't get enough lymph nodes, we tend to treat them like they're stage 3. We assume the worst and give them chemo.
But for a standard stage 2?
For a standard average stage 2, it's a long conversation between the doctor and the patient about the potential small benefit versus the definite toxicities.
And stage 3, no gray area there.
No gray area. Stage 3 involves the lymph nodes. The cat is officially out of the bag. Adjuvant chemotherapy is the absolute standard of care here. You have to treat systemically because the cancer has proven that it can travel.
Before we get into the chemo drugs themselves, what about radiation? Where does that fit in?
Here's a fascinating divide between colon and rectal cancer. For colon cancer, radiation has a very, very limited role.
Why is that?
Because the colon moves around in the abdomen. It's not fixed in one place. And if the cancer recurs, it tends to recur all over the belly. You can't safely radiate the entire abdomen without destroying the liver and the kidneys and the small bowel.
But rectal cancer is different.
Completely different. The rectum is fixed in the pelvis. It doesn't move. And recurrences, when they happen, tend to be local, right there in the pelvis where the tumor started. So for rectal cancer, radiation plays a huge role. In fact, we often use it preoperatively.
Before surgery, that's neoadjuvant therapy.
Neoadjuvant, exactly. We give it before the operation.
Why do it before instead of after?
There are two major reasons. One, it shrinks the tumor, which can make it easier for the surgeon to remove it completely with clean margins. Two, and this is a huge one for quality of life, it can significantly improve the chances of sphincter preservation.
Meaning you don't need a permanent colostomy bag.
Exactly. If the tumor is very low, right down near the anus, the surgeon might have to remove the entire sphincter muscle to get clear margins, and that means a permanent colostomy bag. But if you radiate it first and shrink it, pulling it away from the sphincter, the surgeon might be able to save that muscle. That is a massive difference for the patient's future.
That's a life-changing difference. Okay, let's talk about the chemical warfare, the adjuvant chemotherapy regimens. The text lists some heavy hitters: fluoropyrimidines and oxaliplatin.
These are the backbones. Fluorosil, which everyone calls 5-FU, is the old guard.
Yeah.
It was developed decades ago, but it is still incredibly effective. And it's usually paired with another drug, leucovorin.
I always wonder about leucovorin. Is it a chemo drug itself? What does it do?
That's a great question. It's not really a chemo drug. It's what we call a biomodulator. Think of it as a force multiplier for the 5-FU. Leucovorin enhances the cytotoxic activity of fluorosil. It essentially helps the 5-FU molecule bind tighter to its target enzyme inside the cancer cell, so it makes the chemo stay there longer and work harder. It's teamwork.
Teamwork, I like that. So that's the base, and then you have oxaliplatin.
Right. Adding this platinum-based drug to the mix creates the standard regimens we see today, like FOL, FOX, which is probably the most common one.
But these drugs come with a serious side effect trade-off. Let's unpack that, because this is what the patient actually experiences day to day. Fluorosil seems to have different side effects depending on how you put it into the body.
That's right. The delivery method matters a lot. If you give 5-FU as a continuous infusion, a slow drip over hours or even days through a pump, it tends to cause something called hand-foot syndrome.
What does that feel like?
The palms of the hands and the soles of the feet get red, tender, swollen, and can even peel. It can be incredibly painful to the point where it hurts to walk or even hold a pen. It also causes stomatitis, painful mouth sores.
And if you give it as a bolus, like a quick injection?
Then the toxicity profile shifts completely. You see less of the skin issues, but much more myelosuppression, specifically leukopenia, a sharp drop in white blood cells. This is dangerous because it wipes out your immune system and leaves you vulnerable to life-threatening infections.
Then there is oxaliplatin. The text mentions neuropathies. This sounds bad.
This is the one patients remember and often fear the most. Oxaliplatin causes nerve damage. It starts as numbness and tingling in the fingers and toes. For many people, it goes away after treatment stops, but for some, it can be permanent.
And there's another strange side effect, right? Cold sensitivity.
It's a very bizarre and specific acute side effect. It's a sensory short circuit. If a patient on oxaliplatin touches a cold doorknob or reaches into the freezer for a bag of peas, it can feel like they're grabbing broken glass.
Whoa.
If they drink an iced tea, it can feel like their throat is closing up or they're swallowing shards of ice. It's acute and very specific to this drug. Patients have to learn to wear gloves just to get milk out of the fridge.
There's also a very specific and scary warning in the text about a genetic deficiency, DPD.
Dihydropyrimidine dehydrogenase. Try saying that 3 times fast. It's an enzyme in your liver that's responsible for breaking down fluorosil. Most of us have it, and it works fine.
And if you don't?
If you are part of the small percentage of the population that is deficient in this enzyme, and we give you a standard dose of 5-FU, your body simply cannot clear the drug. It builds up to massive toxic levels.
What happens then?
It can lead to severe toxicity, multi-organ failure, and even death. It is rare, but it is catastrophic when it happens. This is why some centers are now testing for DPD deficiency before starting treatment.
One final point on the adjuvant section age. The text suggests an age cutoff for adding oxaliplatin.
Yes, this is really important. When you look at the subset analyses of the large clinical trials, they've shown that patients older than 70 might not get the same amount of benefit from adding oxaliplatin to their regimen. The survival benefit is much smaller.
But the toxicity is the same.
Or even worse. So we have to weigh if it's worth it. For an 80-year-old, the risk of falling and breaking a hip because they can't feel their feet from the neuropathy might far outweigh the 1 or 2% cancer benefit. Sometimes, just the fluorosil is the better, safer choice.
Okay, we've covered the localized fight. Now we need to move to the advanced arsenal. We're talking about metastatic disease, MCRC, stage 4. This is where the landscape gets even more complex.
This is where the entire philosophy of treatment shifts. For most stage 4 patients, the disease is technically considered incurable. The goal shifts from cure to palliative care.
Palliative doesn't mean giving up, though. I think that word scares people.
Not at all. It's a common misconception. Palliative comes from the Latin word to cloak or to improve symptoms. In this context, it means controlling the cancer growth, reducing symptoms, improving quality of life, and extending survival for as long as we can. We have patients living for years with metastatic disease now.
But there is a huge caveat in the text. It says 20 to 30% of metastatic patients can be cured. How is that possible?
If the metastases are resectable, meaning if the spread is limited, say just a few spots in the liver or a single spot in the lung, and we can go in and surgically cut them out, we can still aim for a cure. We essentially treat the metastasis just like we treated the primary tumor.
What makes someone an ideal candidate for that kind of aggressive approach?
You want limited disease. The benchmark is usually fewer than 4 lesions. You want them to be small. You want a CEA level that isn't through the roof, preferably less than 200. And of course, the patient has to be healthy enough for major surgery, and you need to be able to leave enough healthy liver behind to function. You can't remove 90% of the liver.
The text mentions some really high-tech ways to attack liver tumors besides just cutting them out. One is hepatic artery infusion, or HAI.
This is an incredibly clever way to exploit the liver's unique anatomy. The liver gets its blood supply from 2 sources, the portal vein and the hepatic artery. Normal liver cells get most of their food from the portal vein. Liver tumors, however, are greedy. They get almost their entire blood supply from the hepatic artery. They have a different fuel line.
I see where this is going.
Exactly. So with HAI, a surgeon implants a small pump that pumps high-dose chemotherapy directly into the hepatic artery. You are flooding the tumors with a high concentration of poison, while the rest of the healthy liver is being fed by the clean portal vein. It protects the rest of the body from systemic side effects while just hammering the liver tumors.
That is incredible biological engineering. And then there is ablation.
Ablation is basically cooking the tumor. We use probes that deliver either radiofrequency or microwave energy to heat the tumor cells to the point of destruction. It's generally less successful than surgery. There's a higher chance the cancer comes back locally, but it's a great option if a patient is too sick for a major operation or the tumor's in a really tricky spot to get to.
Now, for the majority of patients who have unresectable disease, we are back to systemic chemotherapy. And this is where the text emphasizes a very personalized approach.
You absolutely cannot just pick a regimen off the shelf anymore. The decision depends on what chemo, if any, they have had before, their overall health. And critically, You have to look at the KRAS mutation status of their tumor.
Let's look at the alphabet soup of regimens again. We have Afelifox and Catbox, which are oxaliplatin-based, and then we have Fulfari.
Right. Fulfari is the other major first-line option. It swaps the oxaliplatin for a drug called irinotecan.
And irinotecan has its own nasty reputation, right?
It does. Its major dose-limiting side effect is diarrhea.
Yeah.
We're not talking about regular diarrhea. We're talking about both an early onset and a late onset diarrhea that can be incredibly severe. It can cause life-threatening dehydration and electrolyte imbalances if it's not managed aggressively. It also causes neutropenia, just like 5-FU.
So now we get to the biologic weapons, the targeted therapies. These aren't just poisons that kill any fast-growing cell. They're more like precision missiles. Let's start with bevacizumab.
Bevacizumab, brand name Avastin, is a monoclonal antibody. It targets something called VEGF, vascular endothelial growth factor.
In plain English.
Tumors, once to get to a certain size, need their own blood supply to keep growing. So they secrete VEGF, which is a signal to the body that says, hey, build new blood vessels over here. I need to be fed.
So they trick the body into feeding them.
They do. Bevacizumab blocks that VEGF signal.
Yeah.
It prevents this process, which is called angiogenesis. It basically starves the tumor of its blood supply.
And does it work?
It definitely increases survival when it's added to standard chemotherapy. But because it messes with blood vessels and the body's ability to heal, it has some unique and serious side effects. Hypertension is very common, but manageable. But the really scary one is GI perforation.
A hole in the gut.
A hole in the gut. Because it stops blood vessel growth, it can cause the bowel wall to weaken and burst. It's rare, maybe 1 to 2% of patients, but it can be fatal. If a patient on this drug complains of sudden, severe abdominal pain, vomiting, or constipation, you have to evaluate them for a perforation immediately.
Now, the other major class of biologics, the EGFR inhibitors, cetuximab and panitumumab. And this is where that KRAS test becomes literally a life or death decision.
This is the single most critical example of pharmacogenetics in this entire chapter. These drugs target the epidermal growth factor receptor, or EGFR, which sits on the outside of the cancer cell. Normally, when you block this receptor, it stops sending a growth signal to the nucleus.
Okay, so you block the receptor, the cell stops growing. Simple enough.
That's the theory. However, the signal has to travel from that receptor on the outside down a chain of proteins to get to the nucleus. And KRAS is a key protein in that signaling chain. It's like a relay runner.
And what happens if KRAS is broken?
If the KRAS gene is mutated, specifically at codons 12 or 13, the protein that it creates is permanently stuck in the on position. It's constantly sending that grow signal, regardless of what's happening at the receptor up top.
So it doesn't matter if you block the receptor on the outside of the cell.
It doesn't matter at all. If KRAS is mutated, the switch is stuck on downstream. You can lock the front door all you want, that's the receptor, but the party is already happening inside the house, the nucleus. The signal is already on.
So if you have a KRAS mutation, these expensive, potent drugs are completely useless to you.
100% useless. They will not work. That is why the text is so emphatic that these drugs are only indicated for patients with KRAS wild-type tumors. Wild-type, meaning normal, non-mutated KRAS. You must test the tumor before you even think about prescribing these.
What happens if you give them to a KRAS mutant patient?
You are just giving them all the toxicity with absolutely zero chance of benefit. It's medical malpractice at this point.
And if you are wild-type and you do take them, what's the price you pay in side effects?
The hallmark side effect is an acne-like skin rash. It's very common, usually on the face, chest, and back. In fact, there's some good evidence that getting the rash actually correlates with a better response to the drug. It's a sign that the drug is hitting its target. But it can be physically uncomfortable and socially difficult for patients to deal with.
The battle against metastatic disease is often a long one. Patients eventually progress. The drugs stop working. What happens then? The text talks about second-line strategies.
The standard approach is to switch. If you started on an oxaliplatin-based regimen like FOLFOX, we then switch you to an irinotecan-based regimen like Fulfari, or vice versa. We try to expose the tumor to a different mechanism of attack. The assumption is the tumor has developed resistance to the first drug, so we hit it with something it hasn't seen yet.
And there are newer drugs for this phase too. Zivaflibercept, that's a mouthful.
It is a tongue twister. It also blocks angiogenesis, similar to bevacizumab, but it acts as a VEGF trap. It's designed to catch more of the growth factor targets. It's approved for use in the second line, always with Fulfari.
And regorafenib.
That's an oral pill. It's usually a last resort, third or fourth line, for patients who have progressed on everything else. It's what we call a dirty kinase inhibitor. It hits a lot of different targets inside the cell. Because it hits so many things, it causes a lot of side effects.
Yeah.
Hand-foot syndrome, fatigue, high blood pressure. But for a patient who is running out of options, it can buy them some precious time.
So we've treated the patient, now we have to watch them like a hawk.
Section 5, monitoring and evaluation.
Mm.
How do we know if any of this is working?
In the metastatic setting, we're constantly monitoring. We watch the tumor size on CT scans every couple of months, and we watch that CEA tumor marker level in the blood. But we also have to monitor the patient. The side effects we discussed, the diarrhea, the neurotoxicity, the hypertension, can derail the whole treatment plan.
You can't just push through.
You can't. You can't cure the cancer if the treatment kills the patient or makes their life so unbearable they want to stop. We often have to dose reduce or take breaks from treatment to let the body recover. It's a constant balancing act. What about recurrence after the initial treatment for localized disease? The text says less than half of patients who recur actually develop symptoms.
That is a frightening statistic, isn't it?
Mm-hmm.
You can be cancer-free, feeling totally fine, but the cancer is quietly growing back. That's why we rely so heavily on that rising CEA level in asymptomatic patients to trigger new scans. We're basically hunting for ghosts before they become monsters again.
I want to circle back to pharmacogenetics one last time because the text has a really counterintuitive point about MSI-H high microsatellite instability.
Yes, this is so fascinating. We usually think of more mutations as being bad, but for patients with stage 2 cancer, if their tumor is MSI high, they actually have a very good prognosis. Their own immune system seems to be better at recognizing the messy, unstable DNA of these tumor cells and keeps them in check.
But there is a huge twist regarding treatment for them.
This is the twist. Because these tumors are biologically different, studies have shown that these specific patients actually do not benefit from adjuvant fluorouracil. The standard chemo doesn't help them. In fact, some studies have even suggested it might be slightly harmful.
So knowing that saves them from treatment.
It saves a patient from 6 months of toxic chemotherapy that wouldn't have done them any good in the first place. It is another massive win for personalized medicine.
So we've gone from the silent first mutations all the way to the genetic profiling of late-stage disease. If we were to summarize this entire deep dive...
Well, if we zoom out, the journey is pretty clear. It starts with the absolute importance of screening at 45 or 50. Prevention is always better than cure. Then it's about accurate staging. You have to know the enemy's location and spread. And finally, it's the sheer complexity of choosing the right chemo cocktail, now completely guided by genetic markers.
It really emphasizes that critical distinction between colon and rectal cancer treatment. They're right next to each other, but they require very different surgical and radiation approaches.
And the absolute non-negotiable necessity of knowing your tumor status. You simply cannot treat metastatic colorectal cancer effectively in the modern era without knowing your KRAS status. It's that fundamental.
If there's one thing to take away for our listeners from all of this, what is it?
For the general listener out there, silence is not safety. This cancer is silent until it is loud. Screening isn't just a suggestion on a brochure. It is your primary defense. Do not wait for symptoms like blood in your stool.
And for those who are in treatment or have a loved one in treatment.
Personalization is not a buzzword. It's not a luxury. It is about your specific tumor genetics, your KRAS status, your MSI status, dictating your survival. Advocate for that testing. Make sure it's being done.
Before we sign off, you had a provocative closing thought for us based on all this data.
I did. We discussed how aggressively removing metastases can now cure 20 to 30% of patients diagnosed with stage 5 of disease. That's a number that was 0 not that long ago.
Right.
So it makes you wonder, as our surgical techniques get even better, as our drugs get better at shrinking tumors to make them resectable, could stage 4 eventually lose its reputation as a terminal diagnosis? Could it, for the majority, become a chronic, manageable, or even curable condition?
From a death sentence to a manageable condition, that is definitely something to think about and something to hope for. Thanks for listening to this deep dive.
Stay curious and stay healthy.
See you next time.